Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 151. Being the first session in the new year, a very happy new year to you, although the last 2 weeks with the Omicron seems already a long time. We have a truly complex distal left main bifurcation case. And I hope you're going to learn a lot of practical lessons. Nobody does left main or even otherwise more bifurcations than here at Mount Sinai. And I think what you may be impressed the most with is the simplicity of the procedure. And hopefully there are going to be many tips and tricks. Please keep it interactive. I'll try to answer all your questions. And with this introduction, let me take you to the cath lab. Samin, Anu, good morning.
Okay.
Morning.
A very happy new year to your staff. Already looks a long way into the new year.
Yes, and of course we welcome all our CCC live viewers, which makes to now almost 30,000+ per month. And we start with the very interesting case. It's not a super complex, but a very technical point. In this particular case, we are going to show, and actually start with the volume next, because people start the slide, please. We all were concerned what will happen with 2021 compared to 2019. So this is the volume at Mount Sinai in last 5 years. You saw that there was a dip in 20, which we knew. So what we did is we compared ourselves with 2019, not with 20. So clearly a growth with a total cath procedures and intervention from 5,100 to 5,275. So these are the individual coronary intervention, the valvuloplasty, endovascular, and tower significant growth in tower group from 370 to 453, and the mitral clip 52 and other procedures are in the center. So this is basically the field continues to evolve and trying to do from volume. Now, volume is one part, then you have to talk about safety. The safety is, these are our complications, including patient with cardiogenic shock. We lost 13 patients total. So the 6 of them were in shock and 7 non-shock of the 3829 cath procedure or PCI we did. And the cabbage, as you see, the number remained less than 1%. So overall, very happy for growth of 5 years. Now, you always want to compare yourself with others. So actually New York State helps us out. Gives us the data, but they do what they have published already in the past. So you need to compare with their 2017 to now current 2021 numbers. As you can see there, numbers are a little different because they take it from December to November. And so, but overall in hospital mortality is half, the stroke rate, the cabbage, you see all point we do great, including vascular injury, which used to be a little high, but radial now about 45%. That number has gone down, but we still have a little outlier in coronary perforation, and of course maybe largely because of the complexity of the cases. So clearly only one height, I would say the tall bar left is the coronary perforation, which our goal is to work on it in 2022. Now then the ACC NCDR gives you the running quarter, though this is the last running quarter of 2020 and 21. The data, as you can see, risk adjusted mortality is half of, and of course same thing in hospital death of the STEMI patient, cabbage, stroke, major complication, excellent outcome in all those with the length of stay. So they define major complication as death, urgent cabbage, stroke, or emergency target vessel revascularization. So that number was 0.4 for Sinai in the running 1 year quarter compared to 2.8 for the, so we had the 15% of the national average. So clearly, and of course, I would say the part of the success is complex cases using appropriate atherectomy, majority being rotational, then of course orbital, and now we have added IVL and the Impella. Impella used about 3% of cases, and so. So with that note, we are ready to start our case number 151. These are our supporters, all the disclosures. This patient is a 68-year-old female, had a PCI in 2005, long time ago. Did okay since then until recently when he started having angina. And had a positive stress test for multivessel ischemia and risk factors on the left side. We always check the SAQ 752 means patient is moderately symptomatic. Number towards 100 is good, 0 is bad. Then variables are basically a patient was medical therapy good until cath done last month, which revealed 3 vessel and left main disease, and with a patent stent of the LAD cipher of 2005. Did have a distal left main. Anu will show the angiogram. That lesion is in the distal left main, not involving the proximal ostial LAD or within 5 millimeter of the LAD or circumflex. Lesions are in the LAD and circ further down, and had a, because of that RCA intervention, LV was normal and had a 2 stent in the right coronary artery. Yeah, no.
So normal EDP, normal EF, and this is where we are with the right coronary artery, patent stent. Rest of the vessel looks normal. This is the left main, significant distal left main disease, and proximal circ, again 90%. So proximal LAD, there is a disease before the septal. You can appreciate in this view. The stent, which is in the mid LAD, looks okay, involving the DAG. So you can see the lesion in the LAD before the septal. The question comes, how bad is the so-called true bifurcation?
Yeah, tell us what will be your strategy, because this is by definition is 100.
Yeah.
There will not be a bifurcation. There are lesions in the LAD, proximal circ. They are 5 millimeter away from the bifurcation.
Now I'm trying to see, is it safe to do, we'll do a guide shot now.
Yeah.
Whether
So-
it is safe to do IVUS with the tight distal left main, yeah.
In terms of
Before.
calcification?
Yeah. Angiographically, I don't think there's a lot of calcium. We could probably do it without
Go.
atherectomy.
Yep.
So, I mean, before I start bringing the questions, congratulations on a remarkable performance at the hospital, to continue leading the state, to be a leader nationwide, just fantastic. And I think also one of the larger uses nationwide in atherectomy, wonderful rates. I think quite balanced with 3% of impella, just outstanding.
So the wild picture is being taken. So our whole idea is that even if because you have the distal left main, you had to do a crossover, and then you have tight lesion in the circumflex. So it could be okay that we do a stent from the left main to circ and put an additional stent in the LAD. We can go back to slides. Or question could be that you just do a mini crush. So that's basically the plan is. Now residual syntax score is 26. And I was imaging guided to see whether you need to do atherectomy or not. And the lesion, we have taken 3 lesions. Left main, proximal LAD, and circumflex, which are not at the bifurcation. So this is basically by definition, this patient will fall into, because a left main and 3 vessel disease was rarely indicated. So it means by definition inappropriate. But one should do, what is our guidelines are, that you have a heart team discussion. We had a heart team discussion. We had note from the surgeon. Surgeon saw the patient and documented that PCI is okay. So this basically, after heart team discussion, A, because of appropriate, because after ultimately the patient decides. You give all the factors to them, and that's where we are now. Go ahead and do the RCA was done, and now for the left main. No.
Get the wire again.
Yeah. So question is the guide catheter 7 French. We use the VL. VL 3.5 was a little too big, and this is the 3.0. Yeah, 3.0 will be okay. So you should be all right.
And once again, the 7 French is for a dedicated 2-stent strategy.
Yeah, because we think that we might end up in putting the mini crush is always better to go with the 2. Although yes, 6 French could be okay, particularly when you are trying the DK crush or reverse crush, your 6 French will be good enough. And here it looks like maybe you need a little bigger one. No, maybe not. But let's see a little dive first here. No. Yeah,
several questions have come talking about left ventricular support here.
Yeah. So same, this kind of case, since it's not a calcific, not a bifurcation, and normal ejection fraction, it's particularly reasonable not to do it. Somebody wants to do, be comfortable using, I would say nothing against it, because these are the kind of cases, they have the approval of using the impeller device, but we would not, and EDP was normal. So by all telltale sign in this particular case, it's reasonable that we don't use it. If necessary, we can rapidly put it. So by teaching point of view, I would say that if would have been a bifurcation left main, even with the normal EF, I would have said, let's go with impeller. But in this particular case, is okay. Anu, you want to answer that question?
Unusually long and a large circumflex here.
Yeah,
very large territory. It's just, Anu, your thoughts on the support device here? Or
no, since the EF is normal and
right.
I don't think it's really a complex left main. So I think we should be able to do it without a support in this case. Going back to, I think, again, multiple angiography, we do not see there's a lot of calcium. We could probably do it without a atherectomy.
Yeah.
So let's just IVUS into the circ, right?
Yes. Circ or
the
LED?
decision?
No, I would say LED. I think I was in the LED because circ lesion is quite tight. Let's go to the LED. Yeah. Yes, sir.
Not that way.
Congratulations coming to you from Pakistan, Dr. Sohail Rashid, congratulating on the Mount Sinai statistics.
Yeah, very tough. You know, it happened that provided require a lot of efforts. While many of the hospitals, the volume was down, but because of the hospital support, the fellows, the rest of the team, the nurse practitioners, getting all this COVID, you know, a lot of struggle. Bringing those patients, it almost takes double the time nowadays to get them on the table. And particularly now with Omicron, almost 20% asymptomatic patients are becoming positive and they're being cancelled. And then you have to wait for 10 days.
Well,
so
also for you to maintain your staffing at the appropriate levels must be a big challenge.
Yeah, big challenge, but cath lab staff, well, that's why a lot of people in the hospital are very much concerned that how come the cath lab still continues, because all the staffs are dedicated. I'm so thankful to our cath lab team. You need to make a little better, Carl. That they continue to be, and knowing that the challenges are there. So we are open 3 Sundays a month, and those Sundays we do about 25 to plus elective cases, and then whatever the in-house cases are done. So that's remarkable. And then the fellows, I mean, clearly you need the staff in all the aspects, and particularly nurse practitioners, scheduling team, that going through all the challenges of COVID, make sure the COVID is correct. Many times COVID has been expired on day 6. So now you have to figure it out what to do, because it's within 5 days rule. So all these challenges really took extra toll on 2021. So all the numbers looks very good, but yes, the really lot of hard work went in. But I'm thankful to our Mount Sinai Cath Lab team in every aspect. I cannot say which group in particular, but everybody helped out to get to these numbers. And of course, my attending and Anu. Yeah.
Always teamwork. So much of it.
Yep. Now you see the very angulated ostial LED, but it's okay now. It I think went to diagonal. That's okay. Right?
No, it's going to a small, very small diag. I think I need a fielder then.
If not, you can take a fielder.
What wire is this? This is
the run through. Yeah.
Right.
Yeah. Because by the time it comes out of the lesion, it loses its shape. You want a fielder?
I don't know, fielder or Miracle 3.
No, fielder. Your fielder will work.
So these are the challenges that you don't predict. You think this is a straightforward lesion, should be your workhorse wire. So now we are going with fielder, which is polymer jacketed as well as hydrophilic coating. No tapered tip.
It's a regular fielder.
Yeah.
Yeah, so coming back to the volume point of view, we don't know exactly that whether we are number 1 in the country. We definitely are by every numbers, we are number 1 in the New York State. The second one will be like 2,500 per center. But in the country, we might be second because
Right.
some
There are
data
a
was
few
shown.
places in
Florida,
Orlando.
in Florida.
Orlando, yeah.
Orlando, there's one place only, which seems to be have done 4,500 interventions, 4,600, and we are about 3,800. So we may be second. Yeah.
2,000 operators who come and operate.
Yep, and multiple labs like 14, 15,
amazing,
and so yeah.
Amazing place. I'm very
Can we
familiar
get
with
a
them.
Miracle 3? Yeah.
I was even thinking you may even consider something like even a whisper wire to make that sharp. But yes, exactly. No way to predict cases which look relatively straightforward, and that's the tightest lesion you're approaching now in the circ.
Yeah.
And yeah, for the circ, both challenges. Yeah.
Even this one is not getting into the circ.
Do you want to go to some caudal view only? Just caudal.
I don't think SS.
Because the it is so you can see the upward takeoff of the case. Yeah.
Okay, now. Some die. It's not that. I see that small ramus. That's where it's. Wow. Okay. At least this one went through.
They'll die. So you want to keep this wire into the circ and go with another wire side by side, whether your Miracle or Whisper or retry with the run through now after putting a wire into, because that will change the geometry of the lesion a little bit. Even this is having a little difficulty going into the circ.
Lots of difficulty.
Yeah.
Okay.
I think for a moment you were across.
You need yeah. I think again it's going to that small little OM. Okay, Miracle.
So this is the Miracle 3? Okay.
So Samin, have you expanded your interventional fellowship program with the increasing volume, particularly the increase in the structural heart?
Yeah, so we made 3 structural fellows now. Not with the
interventional fellowship, it's the same.
But interventional fellows are already 6 GME, 2 non-GME.
7 ACGME.
Yeah, 6 to 7 and 2 there. So we are already 8 plus there. 1 maybe hybrid, and then 3 structural and 2 endovascular.
And of course,
15 member.
Mount Sinai has become the world capital of generating interventional cardiology apps.
And the female, actually the Dr. Negar Salai on my right side, she's assisting now. She actually will be our structural fellow, and she was featured in TCTMD.
Wonderful!
Just last
Congratulations!
Week.
Yeah, I see her working diligently in the fellows' room in between cases.
I think they then need to go with the supercross or something. You want to go to another cranial view?
Okay, go to epicranial then.
So it has to be this view.
These VL and
RAO 1145.
Yeah.
VL and XB support catheters are so simple to use, but many years ago this used to be a standard Amplatz case. More for the circumflex. But,
yeah.
Now that I.
So now this could be that if your wire goes into the circ, it's okay to modify the lesion before getting into the LAD. Or you can always use the angulated catheter now, either supercross or venture. Yep.
Okay. I don't know.
Yeah, what is this? See this? Is this the LAD?
No, this is circ. Should we go with a fine cross then?
Okay. No, but fine cross or you need some angulated catheter here.
Okay.
We did it now.
Into the LAD.
you just had to scare it
Yeah,
by using.
yeah. Okay.
Several people have been wondering if you would be moving to a microcatheter. So
Yeah,
all
micro and
exactly
more
good
importantly
thoughts, good
angulated. Yeah,
thoughts.
yeah, of course, absolutely.
All
So this,
correct.
yeah. So this kind, of course, if we wanted a rotablation to definite, we would have gone with the microcatheter. Here it's a questionable. So it's a reasonable to look into it. The lab which does 24% because of the selected referral pattern. So we do the IVUS and then we make a decision.
You want IVUS? I
Yeah,
will not do it.
IVUS. That was the whole purpose, was to do whether rota is needed or not based on the calcium.
I don't think at this time we should just
Huh?
balloon stent it.
Okay, but let's just, since we have it, you're able to get this. We still then have a challenge of putting a wire into the circumflex still. This is the Miracle 3. Tell us, why did you select Miracle 3 versus more
I think
hydrophilic
you
and
needed a hydrophobic tip there, because hydrophilic tips, which both you have the run through as well as a fielder, there is a hydrophilic coating. Now a fielder is a polymer jacket plus hydrophilic coating. The tip of a run through is also has a hydrophilic coating. So you know they were just going into that small branch. So you need a little hydrophobic tip, which easy to navigate into that curve of the LED.
Good.
Okay, so
That's
I'm
it.
there.
Okay.
Start the IVUS.
Yep.
Imaging.
Slow, don't keep it.
There to show the IVUS.
IVUS, yeah.
Yeah, good.
Okay, start pullback. So this is not in the stent native vessel. Like 1 quadrant calcium, 1 to 2 quadrant calcium. Lumen is bigger. Yeah, here's not so much plaque. A little bit back. Yeah, eccentric calcified plaque. Like 1
That left
quadrant.
main.
I come to left main.
Mm.
Yeah, tightest part.
More
Getting bigger.
calcification in the left main. Huh?
Yeah.
Yeah,
But
but
it's
not
about
a heavy-
180,
yeah.
right?
Yeah.
Is there anything more than 180?
Yeah,
At most, yeah.
not 3
Yeah,
quadrant.
that's okay. Then fine. I
It's
mean, I
okay.
think this is okay. That's our feeling was. Based on the angiogram, we tell everybody the severe calcium you detect on the angiogram 98, 99% of the time. This is the moderate calcium. You may be able to diagnose more with the IVUS and so mild to moderate, but that we showed in our trials that doesn't matter anyway. It is the severe calcium which gives rise to bad
So go
outcome
back to the distal left main.
in our MACE trial. Yeah.
Yeah. So this we should be okay with the
Yeah. See that
balloon.
is interrupted and to be a cutting balloon will be okay. With the but anyway, let's wire the circumflex. Go
For
back
that
to the
I
quarter.
need a fine cross. But then my goal was that we have to change this. You don't want to leave this wire in the LED. You want to leave this wire in the LED?
Yeah, that's fine.
Okay. Why don't we dilate the LED and then
Okay.
wire the
Fine. Sir, that's okay.
circ.
Yeah. Let's get a
I
cutting
need
balloon.
fine cross.
3O cutting balloon.
Yeah, okay.
Yeah. Give us a 3O cutting balloon. Yep. Good.
Do you see osteal circ, no disease, right? Will we IVUS the circ? Based on this, you mean we can stent across? Put a short stent in the circ and then in the left main?
That is fine. But after putting the stent in the circ, yeah. So that is one way. Or other one was the mini crush. So this is okay. With good circumflex, you want to leave that alone and put a stent across, one stent there and then across is reasonable also. Okay.
If just wanted to ask Casey how much was the left main circumference he got? Probably a 450 maybe.
Yeah, it will be less than 5. Huh? Go to left main.
Yeah, so this is this.
Yeah, how much it is?
4.5.
So the
Good, too far.
tightest area 4.3. This are left main.
4.36. Good. Ready?
Yeah. Give me fielder fine cross, okay? Okay, down.
This is ostium of the LED.
And distal left
So
main.
this is
I mean,
distal
more of a
left
distal.
main.
You want to go
Yeah,
proximal area,
more distally.
and yeah. So that will be near the septal.
Okay,
I
down.
think you may need to go a
You want
little bit
to
further.
wire by side. Check with the run through now.
Yeah.
That we disrupted.
Yeah, go a little further in first.
Go up here again.
Okay.
I want to do.
Pull back a little bit. You want to see where the ostial left main? I mean distal left main.
This is the distal left main. No? Down. So little die. Okay.
Pull
Go
back a
back.
little. Yeah. Yeah, now we are. So this is a trio, flextome at 16 Wolverine at 16 atmosphere. Wolverine you can go to 16 to 18. People are always worried about, but we can always go. And look at the
We
ST
see some
depressions and so.
EKG. Can we show the hemo?
Show the EKG now. Good. Want to go here?
Yeah.
Absolutely all right. No changes there.
But some ST
No, there's ST
yeah, in that
depression.
ST depression, yeah.
And lateral
mild
ST
ST
elevation.
Yeah. Good.
Give me the run through wire. Oh, I have it here. Yeah.
Yeah, let's give some medicine first as soon as you come out with this, because there is ST elevation
a
here.
little more now.
Yep.
No, it could be all circumflex. It was almost subtotal lesion, right?
Get a little verapamil. Yeah. Normalizing, yeah, good. And take one picture.
Not yet. Oh, okay. Same view?
Yeah, this one, caudal. Good. It's probably
At
more
least the
circumflex, yeah.
Yeah, I told you.
Yeah.
Circ flow is
Do we
all
need
there
a
still.
new?
Yep.
I want
Good.
to see. Give me a new run through wire.
Yeah, once fire comes here to clean it. Okay, let's decide what our strategy will be for the circumflex.
I think we place a short stent. We will wire it,
Yeah.
dilate it, and then if you want, we can IVUS the ostium. But it looks like ostium is okay. Then we place a short stent and stent across. Do we need to come up to the ostium of the left main?
Yeah.
Look at the.
Yeah. No, we definitely should come up to the ostium of the left main. Don't have to be hanging out, but we definitely need to be good. Let's go now.
But you
Okay,
would
try to
cover the ostium of the LED or leave that alone?
No, that we do.
Up to the first septal.
Yeah. Up to the first septal, yes.
Right across the circumflex.
Yeah, yes. Good.
Okay.
Very good.
So now we are able to wire with the run through
Yep.
into
So
the
leave it
LED.
there.
A lovely comment, Samin, by a CV technician
want?
from Andhra Pradesh in India,
Okay.
saying, complimenting and thanking you and saying that he has been watching a lot of our videos and he recommends that more and more technicians do so.
Right.
Absolutely beautiful comments. Thank you, Pawan. Exactly right. We do believe that this can be an invaluable source for both nurses and technicians.
Absolutely. And Pablo is our designated the Cardiac CVT. He's actually in charge also, but present in majority of our live cases.
Yeah, this crossed my mind that Pablo has probably been there in just about every case from the beginning. Just about every.
Yeah.
He says he has missed 3.
3.
Okay, all right. Wonderful. Great job, Pablo. An absolutely amazing talent.
So now we have the fielder fine cross. So we are bringing it because we may need a little better tip curve.
Yeah. And some support there. And
yeah. I think now you have to take out and make a better curve.
Yeah.
Or you can get your same, another miracle.
Okay.
yeah,
And to make a better
Whatever.
curve or what?
Yeah, take it.
Yeah.
Turned
we-
out to be
miracle
more,
3 or
wiring more challenging than any other CTO cases. So what we did, we went with fielder fine cross with the first, L-shaped curve. Now I'm making a C-shaped curve. The fine cross is there in the proximal circ. Now if this does not go, I have the same miracle which we will use. Some dye there. Want to give me a run through or a miracle? Hitting the wall, yeah. See, I don't want to go. Dissect it.
Let's decide which one first.
Since
Yeah,
I was
miracle.
always focusing
Miracle.
so much on the tortuosity, I don't know why I kept thinking of the whisper wire.
Yeah. No, the whisper could be okay too. I mean, this one need a little push.
Tortuosity, yeah, absolutely, completely
Ready?
agree.
Wait. Let me make a curve again.
In the meantime, hemodynamics are completely okay.
And EKG, which was
totally
there,
normal,
already
completely.
normalized. Yeah.
ST segment is gone. The mild elevation in the lateral leads is all gone. All right. So
Your guide has to come in a little bit so you can see, and you have to pull back your fine cross a little bit. It's too far in.
And you pull back, then see, it changes the entire thing again. Get the earlier, I think, run through made the turn.
Okay, let's bring the fine cross a little further. Axial length run through or regular run through?
Regular.
Regular run through. Another run through. No. Regular, yeah.
right, it's made the curve and yeah, even.
Ready? I'm taking it out. What do you want?
Make another curve.
So same now, since your fine cross is already there, you can make a more aggressive C type curve. Yep.
You have 300 run through ready, right?
Yeah.
If you need.
Okay. Yeah. Good.
There you go.
You're 300.
Wow, it's very
Now,
tight.
Yep. Good. Very good.
fantastic job.
300.
Fantastic job.
But you want to dock? Huh?
No, 300, right?
We can get dock.
Dock.
Okay. Good. You're quite far.
So you see here the difference. We try to use the same miracle, but you needed the hydrophilic coating, so the wire will go through that curve and make another turn.
320 high pressure.
Which was the eventual wire you got it?
Run through.
Run through. Okay.
First time
Excellent
also
job.
when I was trying without fine cross, run through cross that lesion and then went into the small branch.
There,
That's why I knew run through will likely cross it again. But we tried fielder first. Then we thought it's a tight lesion. Let's try the Miracle 3 that we had.
Good.
Did not make it. Now we have the run through. We pre-dilate. What balloon you have?
320.
That long you want?
Yeah, no, there is a long lesion.
Okay, so we were going to pre-dilate, then I was...
Okay. Yeah, 3 or 50. Yeah.
Okay.
We had it before. Good. Okay, we are going with the 3 of 15 non-compliant.
Amazing how these minor IT transformations occur. I just counted, I've got 12 times more people chatting with me than sending me questions.
That's good. The whole field of
so much
social
easier
media.
Yeah, absolutely. So much easier to do that and
good.
Instant messaging.
Yeah.
Okay, down.
This is 3/15. And we are not going to do anything to the ostium with this.
Go. Yeah.
So there's no injury.
I was ready.
Okay.
I know a fascinating question has
2
come for
millimeter
you.
back.
Yes.
So
Yeah,
the question asked specifically for you is that you were able to cross the lesion with a torquing device or with your fingers?
With my fingers. I think I
Fantastic.
may, yeah.
So, yeah. All
Multiple
right.
times when you see my hands
Pull
and
back
all
2
the
millimeter.
times I rarely use torquer.
Yeah. Now see it? Let's take a picture.
Ready?
Yeah. So without torquer. Yep.
Yeah. Torquing fingers.
Yeah.
Looks
I think there is
wonderful.
some disease, but there is a disease at the ostium. I think, remember, let's just do with a mini crush. So you are guaranteed full coverage.
With mini crush coming up to the left main ostium.
Oh, that's okay. That's LED.
Yeah, still. Okay, let's IVUS.
All right. IVUS will tell us.
Are you able to see through the, why they cannot put, okay. Ceiling camera.
We in the middle
Yeah,
of it,
done.
we were able to see parts of it.
Okay,
Yeah.
okay.
Yeah.
With your finger movements.
Lean.
This wire is covered. Good.
Also, the wire has to be cleaned multiple times all the time. Between blood and dye, it can get sticky. So we're going with the IVUS to the circumflex, and both. Normally, one branch is fielder, one branch is run through. Today we have run through in both the branches.
So your concern is you want to see the ostium of the circumflex here.
Yes. I think it'll be okay, but
Absolutely
We'll see.
proper imaging guided strategy.
come closer.
That's okay. It's enough for the IVUS,
Yeah,
for
okay.
the ostium. Yeah.
Do the
Okay,
IVUS.
image, so the tight part. Okay, start to work.
This is that lesion, proximal
this-
lesion.
After the balloon part. Yeah. Go to the proximal. Still tight. Go to proximal.
We have to show the flora also so we know where we are.
Yeah, looks like prox.
This is
This is
the
ostium.
left main now. Yeah.
Shape. So
Ostium.
I can check the area.
Okay.
Good.
Okay, I stop.
Off. Yeah.
That's the left main now.
Okay. Yeah. Go to cut. I stopped.
Okay.
So,
Do we need
okay,
to
so now I
pre-dilate
can
more?
see the LED from 9 o'clock. So
Okay,
go
let's
to
take
one
this
by
one out
one.
first.
Flush it and have it ready again.
Like
so we go
here,
to the mini
elliptical
crush.
shape, one column calcium.
So no, not pre-dilate. You have to post-dilate anyway. You have to put a stent.
No, it is
Yeah.
tight.
Yeah, that's fine. The tight
This
is
is
okay.
the osteal circ. So yeah, there is a plaque, one column calcium plaque, but the area is 5.6.
Okay.
This is
So
the
let's
osteal
put a
circ.
stent in the circ if you want. We can use a Promus that was used last time. So 3/32.
No, are we covering the ostium or no?
No, but based on this information,
We can do it right,
Yeah,
PSP?
yeah, more than 4. Yeah, you
Yeah.
can read it.
Okay, so
ostium,
then
sir.
we 32.
3/32, and then we can use a 3.5.
I don't think LED needs 3.5. Will be 3 again.
Okay.
And then we have to post dilate the left main.
Good.
Right, LED is 3.
This LED 3.5. Vessel size is 3.5, but concentric plaque. So yeah, 3.5. The O is safer.
Are you sure LED is 3.5?
Yeah,
Go back.
Yeah.
vessel size is 3.5, but concentric plaque.
That's LED?
Yeah, that's the start of the product. That's the level of the septal.
Yeah. No.
Okay,
LED
we're going
will
the
be
circ.
3.5.
We're going to the circ. So we're doing a 3/32 into the circ, and then we will put 3.5/32 again.
Yeah.
Up to the ostium.
For the LED. Yeah.
Or 38 even. There's no harm in that because come to up to the ostium 38. 3.5, 38.
3.5/38.
Yeah. because there's no issue with the branch. The branch is there. We jailed with the cipher, completely patent. Cipher is patent. And we go overlap there and come up to the ostium. Yep.
I mean, I missed
Yeah.
that. How long was the LED stented?
2005.
Oh.
In the mid LED. And it's a cipher.
Mm-hmm.
I have a feeling it will not make that turn. See that?
Right.
Okay.
There you go.
Pre-dilate there.
Okay.
But
You
I
get the
said
same
alive
balloon or
is-
different balloon? We had a 3 earlier.
Okay, yeah, 3
You know, there was that
table.
little calcified plaque which you're seeing there. I bet you
When
it
we
is.
saw,
Or do you want to do a
Yeah,
cutting balloon
the
there?
ostium.
when we saw in the IVUS, remember I said we need to pre-dilate
But do you
again.
want to do a cutting balloon now in that area?
No, I think high pressure will be good enough.
Okay.
I want to cut it. Same cutter. Okay, get the cutter. You have, right? 3
Yeah, we still have it, the Wolverine.
So we're going with the cutting balloon to that proc circ. Have a guideliner ready.
Yeah, 6 French.
7.
7, okay. Use 7 French.
So we'll have double wire.
No. Not yet. The pressure somehow getting low now.
Yeah,
Let's go with our regular balloon.
I told you that.
Okay. Just 1 second. So clearly the Wolverine did not make that curve angle.
Pressure is getting low, guys.
Because the left main. Part of that is the left main, yeah.
Do you want to put a shorter stent? 32 is a very long stent.
Yeah, it probably won't make the curve.
Yeah, never make that curve.
Now go and based
It's
on this we'll know.
angle and calcium.
Yeah.
Okay, it's coming up. Are you giving something?
Yeah. Connect and go negative.
Yeah, a lot of fluids. You have a vein here, right? Don't connect.
No, negative. I want to go negative. He's used balloon.
Yeah, but then you go negative with the.
Yeah, good. Okay. Good. Good, go.
Also, there was, in addition to the pressure being low, each time damping from
Yeah.
the
Left main.
7 French guide. Yeah.
7 French and with the left main disease there, yeah. Okay, so now we are going back with the same balloon.
Well, one of my other thoughts is, would you want to rotablate that ostium of the circ?
Not now, no.
Yeah. Give us a 3020 or 15, another new one.
Yeah, because this one
Huh?
is a trouble. This balloon always never goes back.
Okay. So this was 3 or 15. You want 3 or 3.5?
Get us a 3.5.
3.5.
3.5, 12, high pressure.
Okay, I don't know if you gave something, but hemodynamics are improved.
No,
little damping.
he gave
Yeah.
he gave a little neosynephrine.
Right.
What is this?
Throw that balloon
Huh?
out, 3-0.
If not, then we use the help of Godzilla.
We may need it for this to make a turn.
Yeah.
So this is a 3-0 balloon. Okay.
3.5.
3.5.
good.
That went through quite easily.
Good.
I think that area has been giving us trouble even during
ostium,
wiring and everything. Not
ostium.
ostium, the proximal circ.
Yeah.
Down. Is it a calcific nodule?
Not protruding,
really.
but there the calcium.
Proximal circ. Here,
good.
at this area.
Huh.
Yeah, see that? Okay, down.
Go
Now
2
you see.
millimeter in and then we'll go back again. Coming back and go in. Good. Yeah. Let me go. No, pull
Yeah,
back a little
good.
bit.
Don't go high, go
Yeah.
down.
Now here's the 12. So now we come back in the guide and go back again, and that will tell us whether this will be okay. No. You want to open this here? Let's do a little balloon here. Okay. I'm going up.
And we are not going to stent it.
You see, there is a little
Good.
band.
Down.
Yeah.
No, that ostium,
Yeah.
eccentric.
Angle.
I know
Yeah.
5.6, but still there is that shelf.
Yeah, I
And
mean
very-
that was
good.
very
Now we made
visible
it.
on
Yeah.
IVUS too.
I was, yeah. 16.
Now what's the plan?
And let's pull back again and try to go in now.
Good.
Good.
That shelf is gone.
Yeah,
That
good.
was creating trouble.
Yep. Good. Let's go up here once again.
Go up.
Yeah. So stent will go now.
No. Are we coming up to the ostium? Down.
Yeah.
Now that we dilate it,
Based on this, I think we should come.
then you have to change the length.
Yeah. But it cannot be longer than this. Yeah.
Okay. Then
We
we have
need
to put that
Yeah. Yeah.
later on.
Yeah.
Okay.
Okay.
Get us the same stent again.
Yep.
Once again, the pressure has started coming down.
Yeah. Same. The guide comes in.
Absolutely. Yeah, and damping also at that time.
Yeah,
Exactly right.
Let's go quickly here.
So this is lesion preparation. Again, we tried to do cutting balloon, would not go. But then, since it was not severe calcium, mild to moderate, high pressure balloon with high pressure, 1820 atmosphere. And that too, you see that the vessel was probably 3.0. What's the circumflex diameter we have? But we went with 3.5 balloon with high
Yeah,
pressure.
proximal is 3.5.
No, proximal circ.
Yeah, 3.5.
Yep.
Wow.
Yeah. See, that was the calcific
That
spicule.
was the
Yeah.
plaque, yeah.
You want to bring back the LED stent? Let's put a LED stent now. Good. We are good.
Yeah,
Get
good.
the LED stent here.
3.5?
Ready. We have it
3.5,
ready.
yes.
Yeah. Right here.
So mini crush as a technique.
Yep. Mini crush. So that actually in our e-blast announcement, I said this is what we'll need. And we clearly said it was 100. You see that despite that, actually one of my fellow called me that, why are you saying mini crush? I said, well, you'll know it on Tuesday.
Well, turned out to be far more complicating than
Yeah. Yeah.
which is the purpose of
Sorry, you are right.
the webcast.
Yeah, and with these cases are very, we go so much methodical to select these cases.
You're going to bring
I
it
think looks
almost
good.
to the ostium of the
Ostium,
left
yeah,
knee.
definitely, yeah.
No, I think we are now covering the diagonal.
Yeah.
No, we are not covering the diagonal.
Yes.
This is 38, we can go 32 again if need to be. No, diagonal far away. Yeah.
No, but it's sticking a
diagonal.
lot out. Look at this left
Yeah, you
main.
can go few millimeter advance. Let's see. The diagonal is far away, but you are right.
Some
We
die.
cannot close the diagonal.
No.
Diagonal is still 3-4 millimeter more. If you want, you can go with the LED. This is the LED.
I think 32 probably.
Good,
No?
good,
No. So
Yeah.
that?
good. We are good.
Looks
Okay.
looks to be better position
Yeah.
both the
Now we need to go
left
to
main.
caudal so that don't have too much overlap. We'll do the circumflex first.
Get me a fielder wire to recross.
Ready? Good.
Hold on. This is a circ, right?
Yeah.
Some die. If it's good, I don't have to pull back. Yeah, I think you're good.
Okay. We're going up. We're deploying the circumflex and 32 covers actually the ostium to that lesion in the OM. Say it's a 3.0, 16 atmosphere.
Okay, down. Go up again. So now we'll take the STS and the run-through wire from the circ after this.
So not
Some die?
not unexpectedly, a question has come.
Yeah.
Would you be considering pot for the?
Yeah, left
Yeah,
main. Yes,
left main
definitely.
always has to
Yeah.
have a
Right.
pot.
So exactly
There's the
right.
wire.
They have been anticipating.
Then we have to go cranial just to confirm. Okay. Good. Go to the cranial just to confirm the ostial positioning. For ostial left
this
main,
wire.
we just go cranial. Take a RAO cranial a little bit.
Yeah, we're good.
Pull back a little bit.
Yeah,
No?
1 millimeter maybe.
Yeah.
Because this is the Promus. Promus synergy stent is within the dot.
Okay, some die.
Good.
Okay, go up.
Okay, we are going up now. This is the 3.5, 38 at 16 atmosphere.
That is the fielder. We recross the pot. Now this is always questionable when you recross, before pot, after pot.
4.0. And I don't think it's bigger than left main was 4.0 or 4.5. Wow, 4.5.
4.36 exactly.
want to take
So I
photo?
mean the distal
Photo,
part
yeah.
of this is within the struts of the previous stent, no?
Yes, yep, yep. We're going to
want to
see
take a
if anything
picture?
more need to be done here. Yeah. Yep. Good.
All right.
Go to caudal view.
Injected so hard.
Right.
Went to the side branch.
That's okay. What
Okay,
happened to
good.
the wire?
Nothing, he went to the small
Yeah,
diag.
yeah.
Fielder is ready. Caudal, fielder. So we will, what balloon you have? 4.0, 15. Then we will kiss.
No, 4 or
Let us-
12. 12.
Yeah,
8 or
even a
12.
smaller.
Yeah. 8 or 12. Yeah.
No,
12 will be okay. You have 4 or what we have for 8 or 12. With that
8
we
is
go
too
to
short.
20 atmosphere, 24 will be 4.2 and so.
12 at least minimum.
Okay.
Left main is long. You wanted it to be hanging outside.
Yeah. Yeah, 12 is okay, maximum. Yeah. Okay. All right, now we are going to recross the circumflex.
You want to take a picture here?
Okay. Good.
Looks very nice.
Very nice, yeah.
Ostium of the circ looks perfect. Ostium
Yep.
of the LAD looks okay.
Yeah.
So the plan here would be pot and then a final kissing and
Or kiss first and then pot. So one of them. So a lot of people do pot, repot, and all those. We are not that in favor of that. We'll just
imagine
do
still
one pot.
the ostium of the circ giving challenge to the
No,
wire.
it went in. Yeah, it went in, and then
Yeah.
There we
after
go.
here,
There we
here is a trouble always.
What balloon is this? You're doing a pot first?
Yeah.
Okay. Good.
So when we pot, I'll get into the LED
Yeah.
wire.
Yep. And open the already ostium anyway.
Get us a
Little bit.
3 or 12 balloon. Do you want this same for kiss or separate?
I know
Yeah, we
you're
can use the
putting,
same 3.5
putting the
balloon.
balloon on the LED
three
wire,
of-
no?
Yep.
Yeah.
Right now. Yeah. Good. Going up. 16, 18. We can open the ostium of the LED with this with a moderate pressure. Good.
So I had to bring it back to the guide,
Yeah.
rewrap, and then went forward. Yeah.
Yeah.
Okay,
12 only. Yeah.
Okay, now we have 3.5 balloon. We have 3.5. We used it for the circ.
Yeah, we
So
can do
give
the
me
same.
that 3.5 for the LED and give me we have a 3.0. No, 3.0 12. Yeah.
Good.
So that will be the final kissing, and then we were going to do the. I think the wire came out. A lot of rewrapping.
Yeah. So question, do you want to just take one picture now?
Yeah,
Or,
and you start your thing.
and then we
We'll
start
just
the
do the kiss,
presentation.
yeah.
Yeah. Let's take the picture.
No, the wire came out.
Okay.
Came
One
out
other
of
thing
the
is
LED
no,
or
it's a circ.
Yeah.
A lot of
The
crisscrossing there.
troublemaker
Yeah.
vessel. But now the wire has probably gotten some memory there, and there you go.
Good. Let's take
Okay,
a
ready?
picture. Yeah.
Okay.
As you see, there is no dampening. That means we have
Excellent.
covered the ostium. See, ventricularization, I always say, ostial lesion, you're
So
not
we'll
ventricularized means
start
that
your
you have
lecture.
covered it.
We are
Yeah.
going to kiss and IVUS.
Yeah. Kiss and IVUS, and we'll come back in the end. Meanwhile, we can go back to our presentation.
3.0.
So with that note, the two issues which we always talk about, present some interventional data which were in TCT and AHA. One is the optimum registry, the DES versus cabbage in left main, CAD meta-analysis, then ultra-thin versus newer second generation DES meta-analysis. And the focus review of the month is the impact of lesion calcium on mortality at 10 years after PCI or cabbage in the Syntaxis trial. So basically, in optimum registry, what was it? It's the outcome of PCI in surgically ineligible patient, like surgically turned down, multivessel or left main, prospective registry. And the goal was, these cases, how do they behave? We know that many of them surgeons said very highly complex, cannot do it. So PCI, we don't have real data because these are not randomized trial. None of these patients make to any randomized trial. And so they have the 750 patients, 726 had a PCI with a plan to have 30-day, not only the mortality complication, but also the quality. So angina questionnaire, KCC quality score, and 12-month complete versus incomplete revascularization impact, they will look into it in these cases which were left main and 3-vessel disease. Now, reason for turn down, which most of the time is, we know that it's a poor target and bad LV, and with the COPD and frailty are the more common. And majority of these patients were calcified, bifurcation, CTO, as you can see, and left main was in almost 38% of cases, and mean syntax score was 32, so high. More than 33 was in almost half of these patients. Imaging was done in about 2/3 with a hemodynamic support in 27, atherectomy in 32%, which is very good number, 32%. So basically what they did, by syntax score residual 32 went down to 15. So did a good job overall with a decrease in the syntax because of revascularization as much as possible. Now these were the predicted STS, Euroscore, and surgeon. I think more of a STS and Euroscore. This was the surgeon at site said what will be the predicted mortality, and they found 5.6. So it was in par with the STS predicted mortality of 5.3 in these patients. And you can see here, in 6 months became 12%. So that's a little concerning, that almost double, a little more than double at 6 months. So 12.3 is a very high number of mortality, but these were very sick patients. But just to mind it, that even in the patients with the original our severe aortic stenosis cases, when they compared with the medical therapy, 1 year mortality was 30%. So these are very high risk patients. If I had to extrapolate, we probably will have the similar number, 25-30% mortality at 1 year in these patients. Quality of life questionnaire, which is very good. At 6 months, the height of the red bar improved significantly on each SA angina, as well as almost 82% of patients became angina free. And these are there was also the correlation with the syntax score, less than 8 or more than 8, that those who have less than 8 had a lower 30-day mortality, mean more revascularization, and so. So overall, the risk factor of the 30-day in hospital death, survival, all remain the age, your STS mortality, Euro score, the usual risk factor of patients who have those features, and so. So basically, the idea, the conclusion was that high risk these patients can undergo PCI safely. Yes, the mortality is there, but that is in these group of patients, particularly probably will be much higher if we don't touch them. And so, and maybe the 25 patients who didn't have it, maybe they'll give us the data when the paper is published that how many remain alive of those 25 who had just for on medical therapy, and so. Now, second part is this PCI with the DES versus cabbage in left main individual patient data meta-analysis, and this is what the 4 randomized trial of Syntax, Pre-Combat, Noble, and Excel, up to 5 to 10 year follow-up. As you know that Excel and Syntax have 10-year follow-up, 4394 medium Syntax score 25, so not an extremely high Syntax score. And key is paper came in Lancet where there is a lot of controversy about mortality after PCI versus cabbage in left main disease, and coming by Dr. Sabatine and stamp of Eugene Braunwald. So with basically very nice patient data analysis, they got the data from all the PIs of the 4 trials and they did their own analysis. Very, very interesting. I would say validity to this subject in these patients with the baseline characteristics shown there. And the most important question we needed to answer was death. And this is the slide with the various complications. But look at that. 5-year all-cause death was 1% higher in PCI versus cabbage. So 0.2% per year. So 10.2 in cabbage, 11.2 in PCI. So P very non-significant. Now, once you go to the 10 years, again, same 2% rule remain, 0.2% per year. So in 10 years became 2% difference. So 0.2 per year. So in 10 years became 2% difference. Again, non-significant. So very, very interesting observation. Now the second issue was the myocardial infarction. These are the 0 to 1 and so. So key issue was the MI. MI definitely was higher in the PCI group, and more importantly, spontaneous MI, 2.6 versus 6.2, almost 3.6% difference in favor of cabbage versus PCI. And that we learn all the time in the past. We knew that you have a lower MI, spontaneous MI in the cabbage because they give protection of the rupture of the proximal plaque. Now, stroke rate initially was higher in the cabbage, but at 5 years was caught up and repeat revascularization remained higher. So key is patients particularly with the high Syntax score and multivessel disease and left main, they did derive extra benefit of cabbage versus PCI. So the whatever our working algorithm is, that patient with a high Syntax score and left main and multivessel disease should go for cabbage, remains even with this analysis. So this is a very nice, interesting observation, individual patient data analysis. So basically the editorial was very nice to show the PCI versus cabbage for left main coronary artery disease. Is the jury still out? Although we agree that these data you have to still select based on the patient's preference and present the data to the patient, like this patient. We presented this to the patient, what can be done and what should be done, and patient elected for PCI, which is okay. But key is the after discussion. The third is the long-term follow-up after ultra-thin versus conventional second generation DES, review and meta-analysis. So ultra-thin basically means less than 70 micron, and the second generation, they call it a thicker, but no thicker, thinner. They were between 70 to 120 micron. So key is ultra-thin. There are some data in the past that ultra-thin have a lower TLR and TVR compared to the regular second generation, excluding Texas and Cypher. So these are the cases. So many of them had a 70, like 80, 90 micron. Actually had the 20 micron, and so clear 120 micron. So majority of them were like 80, 90 micron, but the few of them like Orsiro, Me Stent, Biomime, and Supraflex, they were less than 70 micron. And these were the basically, in the nutshell, 16 trials with a 20,000+ patient with a 2.5 year follow-up, and you can see the standard deviation and the relative risk in this slide, and I'll go individually. The TLR definitely lower with the newer stent compared to ultra thin stent versus thinner stent. Then the same ischemia directed, clinically directed revascularization also favored ultra thin strut compared to thin strut. Then MI, no difference. So myocardial infarction, unity 0.94. Then risk of definite and probable stent thrombosis. You can see there may be a little trend towards, but not significant, because the p-value was non-significant. It was 0.70 to 1.06. Maybe some of them has slightly lower, but I think overall we have published our data also. So there's no difference with ultra-thin stenting, stent usage and the follow-up. Death, you see actually, the death actually was slightly better for the thin strut DES. And you know, this paper was initially presented in EuroPCR last year, 2021, and there were a lot of news flash. In their initial presentation, Dr. Madhavan showed that there was a higher mortality with ultra thin, but then they have a follow-up on the talent and biostemy up to 2 years, and then it turns out to be overall no difference, although 0.98, 1.26. Clearly, I would say by definition you have to say no difference in mortality. So basically, to sum up, that ultra thin stents are better in target lesion and target vessel failure, and there is no difference in mortality, maybe a slight trend towards the thin stent compared to ultra thin stents. So this is basically the conclusion was. And then let's quickly go, because they have finished the case, go to the impact of lesion calcium on mortality. 10-year all-cause mortality following PCI. This paper just came out in the JACC intervention of from the Syntaxis extended survival investigator, and showing that what happened to these calcific lesions. Now, these are the various features: patient with a calcium, heavily calcified lesion, which was prospectively monitored or entered in the database of the Syntax in the PCI group and cabbage group. Some have a calcific lesion, almost about same, 30% of them were calcific in both the groups. And in the PCI, rotablation was used only in 3% of cases, which is not unusual. In Excel trial, rotablation was used in 6% of cases, despite having a lot of calcific lesion, or close to half. Now, what we found, which we learned, that is, calcific lesion had almost 1.5 times of mortality. Non-calcific lesion, as such, at 10-year, 22% mortality. Calcific lesion, that number goes to 36.4%. So much higher. Second is that whether you have a left main calcium or you have 3-vessel calcium disease, the calcific lesion have a bad outcome. So clearly, patient with a 3-vessel calcific lesion or left main, which is the green bar, is associated with bad outcome. Now, very interesting observation. That is, when this calcific and non-calcific lesion went for PCI or cabbage, the first blue bars are 26% mortality of the non-calcific lesion PCI and 18.8% with the non-calcific lesion cabbage. So better cabbage data. Now you go to the calcific lesion, there is a 5% in favor of PCI. 34% calcific lesion 10-year mortality, which became 39% in the cabbage group. And these are the individual from 5 to 10 shown there. So it seems to be calcific lesion going for a heavily calcified, I should say, lesion going for cabbage is associated with a higher, little trend towards higher mortality. And this is basically shown in this table, that non-calcific lesion, cabbage better. Calcific lesion, cabbage is not better, rather numerically higher event rate compared to PCI in these cases. And now, particularly you have more than one calcium, cabbage is even worse. As you can see, more than one calcium, they have the highest mortality of 44.1%. And these were the all-cause mortality at 10-year, basically PAD, COPD, heavily calcified lesion, along with the smoker and age. All those which are usual predictors of mortality were the independent product of mortality in this study. So basically, what does that mean? So basically, they said at 10 years, the presence of a heavily calcific lesion was an independent predictor of mortality with a similar prognosis following PCI or cabbage. Whether heavily calcified lesion required special consideration in deciding the mode of revascularization beyond the current contribution to the anatomical syntax score deserves further evaluation. So what I learned basically is that potential explanation of no mortality benefit of cabbage or PCI in heavily calcified lesion. One, older with more comorbidities, COPD, PVD. They were both in the group. But we know COPD, PVD, other comorbid conditions are more predictive in the CABG group compared to PCI group for follow-up mortality. Second, if you have calcific vessel, there is a possibility that there was a poor or incomplete surgical anastomosis. And lastly, post hoc analysis, there could be a chance finding. But these are the explanation. So let me sum it up. Our take-home message of the interventional presentations and the differential impact of lesion calcium on long-term mortality after CABG or PCI. PCI outcome in surgically turned down cases, I would say 2 thumbs up. That finally we have the data to show what it is. Mortality after PCI versus CABG for left main, equal field. No difference in mortality, both up to 10-year follow-up of the PCI or CABG, identical, 2% difference, 0.2% per year, which is insignificant. Spontaneous MI and TLR lower with CABG versus PCI. That's where we have to be careful that clearly, despite our best technique, despite a lot of imaging, spontaneous MI and TLR is lower with the CABG versus PCI in this meta-analysis. Third, ultra thin versus thin newer second generation DES for lower TLR, thumbs up. Other points were not different. Lastly, presence of heavily calcified lesion is an independent predictor of 10-year mortality after both PCI or CABG revascularization. Only a small number of highly calcified lesion, which is 3 to 6%, undergo atherectomy procedures. Long-term mortality is lower with CABG versus PCI in non-calcified lesion, while on the contrary, CABG was associated with numerically higher mortality in calcified lesion. These data calls for better improved and simple interventional treatment of heavily calcified lesion. And I put this one as my editorial. Can IVL fill this gap? And knowing that simple to use, and that's what people are very much interested in going to use it now more and more. Three questions. Following statements are true regarding results of PCI in the optimum registry, except 30-day mortality is in accordance with STS predicted mortality. 6-month mortality is 10 to 15% in these patients. Better health outcome parameter at 6 months. 30-day mortality is similar in low or high residual syntax group. Majority of patients are angina free at 6 months. Answer is D, because lower residual syntax group had a half mortality, like 3% versus 6% if you have a syntax score was more than 8. Second, the patients PCI versus CABG in the left main CAD analysis showed no difference in 5-year all-cause mortality, no difference in 10-year all-cause mortality, no difference in spontaneous MI between PCI versus CABG. TLR is significantly higher in PCI versus CABG group, and lastly, stroke rates are similar in PCI versus CABG group. Clearly, we know that C is wrong answer because there is a higher spontaneous MI with the PCI versus CABG. Last question. Following statements are true regarding the 10-year mortality outcome heavily calcified lesion after CABG versus PCI in syntaxis study. Higher mortality in heavily calcified lesion versus non-heavily calcified. Higher mortality after PCI versus CABG in heavily calcified lesion. Higher mortality after PCI versus CABG in non-heavily calcified lesion. Higher mortality in left main and 3-vessel CAD in patients with heavily calcified lesion versus non-calcified. And medical comorbidities remain independent predictors of mortality. And answer there is B, that there is no higher mortality after PCI versus CABG in heavily calcified lesions. With that note, I conclude my presentation, and Anu is here to show the angiogram as well as the IVUS. Yeah, show where we are now.
Okay, and geographically looks absolutely pristine.
Beautiful.
Everything looks just perfect. Distal left main, ostium of the circ, LAD. Anu, you have images also to show us?
Yeah, we can show. So the final left main was 11.8.
Show the
11.18, and then we can show the IVUS.
No, bring the IVUS on the screen, please.
Anu, and just technically finishing from where we left you, you just did a final kissing there.
Yeah.
Okay.
We just did the kiss, so we can see the...
And what was the balloon sizes you had used there?
Balloon, we used a 3.0 to the circ and 3.5 in the LAD.
Perfect.
Yeah.
So you can show that, and then the final numbers for distal left main is 11, LAD 8, and circumflex 7.
Absolutely.
Exactly, good numbers.
Outstanding case, considering how much you had to evolve the technique as you proceeded. Just exceptional teaching case. Samin, a very comprehensive review of so many relevant topics. One of my, and actually that was there is also a comment, Sanu, for you. Thank you, amazing case. This is by Dr. Yasmid Alequin. Other question for you is, would this patient have fit in the optimum trial?
Yeah,
Probably could, no?
Yeah, no, but in this case, it's not the surgically turned down. So remember,
Right.
Surgically turned down, the cases in the optimum trial were when surgeon said it's not a surgical case. This is a surgical case. This is the patient refused. So patient refused complexity point of view. I mean, yes, syntax score was a little high in this particular case, but this will not be the optimum trial case. Optimum trial was surgeon has to say, not the patient preference. Surgeon has to say it's not a
Got it.
poor target.
Got it. And I think the most fascinating comment you made was, how much does IVL change this whole field? I think, I mean, amazing data that with so much calcification, clearly demonstrating independent risk factors now, both for PCI and CABG, that attention to ablation is so little. And I think that has always been the case, because people found rotational ablation much harder to use. And how much would IVL change? And possibly, it also struck me, just following up your comment, could some of these patients who are going for surgery, could you IVL those lesions before they are bypassed? I have no idea what would be the response to that, but Samin, a great presentation. Anu, fantastic case. I thank the viewers for so much interaction, and we conclude here, and we'll see you on February the 15th.